Welcome everyone to today's GlomCon. It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston. Today we are continuing our clinical trials conference series, which is a joint venture between GlomCon and NephCure. And today's talk is precision medicine for the treatment of glomerular diseases.
Today I just want to talk a little bit about a little background on IgA nephropathy, and then a little bit about our two clinical programs in IgA nephropathy, atrasentan, which is a highly potent and selective endothelin-1 antagonist, which is currently in phase 3 and phase 2 clinical trials in IgAN and some other glomerular disease indications. And then also BION 1301, which is a monoclonal antibody to APRIL, which is in a phase 2 clinical development. So I'm going to share some of the, I think, exciting early data from the BION 1301 program as well. So, as we know, chronic kidney disease is an expensive disease in the U.S. with over $120 billion spent per year healthcare costs related to CKD, but most of that is going towards dialysis. And regulatory agencies have become more interested in surrogate endpoints, as data suggests that some of these surrogate endpoints like protein are really important predictors of progression in CKD. So that's caused a substantial increase in interest, as we've also learned more about relation between biomarkers and proteinuria and progression of kidney disease. So as I mentioned, Chinook currently has two programs in the clinic. Atrasentan, which is a potent and selective endothelin A antagonist, which has already been evaluated in over 5,300 patients with CKD, and BION 1301, which is an anti-APRIL humanized monoclonal antibody, where we already have healthy volunteer data and now some exciting data in IgA nephropathy patients, which was presented at ERA-EDTA this year. We also have CHEK 336, which is a small molecule LDHA inhibitor for primary hyperoxaluria and other forms of hyperoxaluria, which we expect to get into the clinic early next year, and a pipeline of other precision medicine targeted approaches to rare glomerular disease, which we have in the research and discovery stage, and we're looking forward to bringing those new molecules into the clinic as well. So a little bit of background on IgA nephropathy. It's the most common primary glomerular disease globally. About 140 to 180,000 patients in the US have IgA nephropathy. 30 to 30 in other countries, such as in Asia, it's even more prevalent, with as many as 2 million patients, for example, in China with the disease. A substantial proportion of those patients will go on to develop end-stage kidney disease over a 20 to 25 year period. At present, there are no approved treatments for patients with IgA nephropathy. ACE and ARB are considered frontline treatment by the KDIGO guidelines. There has been some data with steroids and immunosuppressive agents, but the benefit hasn't been very consistent, and the safety and tolerability profile of immunosuppressive agents in IgA nephropathy have been somewhat problematic. Recently, there is some new, pretty exciting data from DAPA-CKD suggesting that SGLT2 inhibition may have an important role in glomerular disease. And another endothelin A antagonist, sparsentan, in the PROTECT study, showing pretty significant reductions in proteinuria. So that provides clinical validation for endothelin A inhibition in IgA nephropathy, with atrasentan being the most potent and selective of the endothelin antagonists in clinical development. So I think we can all agree that there is a need for new treatments for this, for these patients, especially the ones that are at high risk for loss of kidney function and development of end-stage kidney disease. So just looking at the multi-hit hypothesis in terms of in the development of IgA nephropathy, at Chinook we have mechanisms